webinar. We are really very fortunate. 3 of our honorary fellows of the college have agreed to join us. Frank Frizzell, who's a surgeon and professor of surgery in Christchurch, New Zealand. Conor Delaney, who's known to, I guess, all of us, trained in Ireland and is now very senior in the Cleveland Clinic. He's professor of surgery, and he's also, Conor, you can tell me exactly, but the chief of the GI section, I think. Maybe there's a different title.
There you go. I chair our Digestive Disease and Surgery Institute. So I'll talk a little bit about that later, Ronan. Thank you.
Okay. And then Professor Mike Griffin, who is president of the Royal College of Surgeons of Edinburgh and is widely known to us as a very prominent upper GI surgeon who practiced until recently in Newcastle. We're going to start with Frank, and quite apart from knowing Frank for many years as a colorectal surgeon and a good friend, Frank has a unique experience in terms of crisis management. Because during the earthquake, Frank found himself having to deal with an acute emergency, which resulted in a lot of casualties, overwhelming infrastructural damage. And one of the things was the management of the acute services. But particularly then, Frank, you found yourself having to reintroduce services when there was the continuing need of the population, as well as the very difficult situation that you found yourself in with the difficulty of delivering that service. So, Frank, it'd be very interesting to have your reflections on how COVID has affected your practice in New Zealand. And what advice you can give us as to how we might safely reintroduce surgery. Thanks, Frank.
Rowan, thank you very much for the introduction. And you're right, this is a little bit of deja vu again, in a way. And I'm just going to start with that as a sort of concept. Next slide. Oh, hang on, wait for the slides to catch up. Yep. So as you can see, we've got one benefit in that we're at the end of the world. I thought you'd be interested in this comparison of New Zealand with Ireland as it stood on Monday when I wrote the slides. We're very similar in many ways. We've got about the same population. We saw our first case within 24 hours of each other. And we're both island nations, but we've got quite different outcomes. And that alters what is possible as far as introduction of services and what can be delivered. Next slide, please. So part of our response is actually our backstory. How did we get here, and what we've learned from previous experience? And I'm just going to touch on that a little bit. Next slide. So as Rowan indicated, we've had national disasters. And, a large earthquake 9 years ago caused complete disruption to our services, to our population, and for a good number of years afterwards, our ability to deliver services. And it allowed us to have a reasonably unique experience in a first world country where you suddenly can't deliver the services that we all accept as everyday services. Next slide. Now this has sort of been further expanded by what's happened in the last 9 years. We've had bushfires, we've had floods, and more recently we've had these mosque shootings, which have all stretched the services, but essentially has made us a bit more elastic in the concept of how we deliver services and how we adapt, and expanded our experience on being able to deliver when we just don't have what we had yesterday. Next slide. And more recently, in the North Island, we had a volcano erupt and kill a lot of tourists. Most of those burn patients were distributed among 2 plastic surgical centres, and the largest number ended up here in Christchurch. So before the Australian government flew over, one of their large planes that they used in Afghanistan for their soldiers, and then put the ventilated patients back on and flew them back to Australia, which I must admit we're immensely glad for, because we just had no more intensive care beds. So everything was full. So what all this is sort of a bit of an idea of the experience we've had over the last 9 years, and the ability to just, in a way, dance around the events that you don't expect that are happening today, that weren't happening yesterday, and weren't even on our radar. Next slide, please. So all these sort of things going on has meant that we weren't entirely surprised when suddenly there was sort of this concept of perhaps a killer virus from China. It was something that we could believe right from the get-go. It wasn't something that we sort of said, no, this doesn't exist. We accepted that it could exist and it could be very damaging, because we were sort of primed in a way to expect the unexpected. Next slide, please. So as this unfolded, because we'd also had SARS close, we didn't have SARS in New Zealand, but it had come to Singapore, and there's many direct flights from Singapore to New Zealand. We'd had an experience with trying to keep viruses out of the country as well. So all that activated our Department of Health and our public health authorities into starting to think about how we're going to respond if this evolves into something. And while we all hoped it was no more than a bad flu, it became apparent relatively quickly as information came out that it was a wee bit more than that. Next slide. So New Zealand followed the same path as every other Western country. If you look at our initial curves there, we sit there with Spain, Germany, Italy, UK, US. We just started off like everything else. So we were on exactly the same curve. Once it arrived here, and the accumulation of cases followed. Now, we were listening to the world talk about herd immunity, about flattening the curve, but no one was really talking about elimination. So that picture at the top there is our Prime Minister trying to explain to a press conference about flattening the curve, and that was our philosophy to start with. Flattening the curve, trying to spread this disaster out over a longer period so that we could cope better. As it actually evolved, our plan changed. Next slide. And you can see we sort of fell off the curve, and that's made a big difference, and that's allowed us to alter our plan. Next slide. We had on Monday 0 cases of COVID-19 in New Zealand, none. There were no active cases. In fact, the last active case was 25 days ago. We do not have community spread. This is completely altered our ability to deal with this disease and our community. And as we were talking before, amongst the presenters, allowed us to introduce rugby again, which of course is a bit like a religion in New Zealand more than a sport. And so various events have changed, and this alters just the whole ability to deliver health care. Next slide. So where to from here? Well, it's obviously got made, the damage of the virus and has had a lot of effects, a lot of unemployment now. A lot of businesses have gone to the wall because we were completely locked down. There was only essential services open for a period there. For a total of 8 weeks, there was nothing. And then there was a reintroduction over 1 month where things were slowly increased until we are where we are today. We're more or less back to normal, other than the borders, which are supposed to be tightly closed. The unemployment's gone up. Education, people are now back at school. The kids were at home. Parents did not like homeschooling. Travel was limited. You could only travel in your own city. You could not go between cities. That's now reopened, and you can now fly around the country. You can't leave the country, but you can fly around. Tourists were left, and the German government and the French government sent planes to New Zealand because, of course, the airlines all closed, and that meant that there was no way out of here, and there was a large number of overseas tourists that were trying to get out. So these countries flew their own planes to New Zealand and took their own national citizens back to those countries. and there was just a series of exit planes. The pilots and staff on those planes were not allowed off the plane when they landed in New Zealand. Food and water was delivered to the plane. They could sleep for 24 hours on the plane, and then they had to leave. That's how tight the doors were shut. But it has a huge impact on health services, which I'm just going to go on to next. Now you've got a bit of an understanding, and you've probably got a bit more used to my accent. Next slide. So there's 5 areas I'm going to talk about: acute surgical presentations, cancer patients, elective surgical conditions, follow-up and screening. And I'm going to cover them reasonably quickly so everyone else gets a chance to chat. Next slide. So acute services, demand was reduced substantially. Like in our service, we get between 30 and 35 acute admissions a day. That fell to early 20s for most days, so that's quite a lot. A lot more people presenting later and sicker. So if someone, instead of turning up for a bit of radiolic fossa pain, would have turned up 3 days after their appendicitis started. Abscesses would be more advanced, and people with perforated diverticular disease more likely that got admitted, more likely to get an operation. We had, like every other service around the world, we had COVID Pacific theatres and the full PPE sort of system. Even though these patients, initially we didn't know how it was going to be community spread, so the whole system locked up to that. Now we're back to just wearing normal theatre gear, normal admissions and all that. There were a couple of things we changed. One is allowing GPs to have direct access to CT scans. We use community CT scanners, so a patient would ring up and we realised quickly from the discussion with the patient, with the referrer, that the patient really was coming to hospital to get a CT scan to see how sick they were. That was done in the community, and then they never came near the hospital if the CT scan indicated they didn't need it. Also, we set up a system where a consultant was available 12 hours a day from 8 in the morning to 8 at night to take GP phone calls and to talk to the general practitioner about the patient and work out whether they needed to come into hospital, 2, whether they just needed investigation in the community, or 3, whether they could be booked into a hot clinic, which was run the next day. And that reduced by about a third of our acute admissions. Next slide. So cancer is a bit more of a problem. All the patients that were waiting for surgery when the lockdown happened got surgery, and that's had an interesting impact because what we've struggled with is actually diagnostics, getting people diagnosed. So there's been a report that's been issued which has assessed the first 2 months of this lockdown, and you'll see roughly the first month there was 1,000 fewer cancer diagnosed. That's a 47% decrease. And they came to the same conclusion we had when we looked at it initially. That report documents the big decrease in diagnostics that was undertaken. Next slide. So these are different cancer groups, and you can see the big fall that's happened with April. And that with the green parts of the slide, so the last 3 years figures are there, gradually getting increasingly dark and green as you get more current, and then April, bang, the big hit. If you look at the graph with the red and the blue lines going up and down, that blue line is, as you can see, is colonoscopies, and you can see the big fall in bowel cancer. We had continued to have enough cancers to keep operating for a while, and now that's fallen. And that's because we have normally about a 2 or 3 week wait from diagnosis to operation for most cancers. So you can just see the on-flow effect, drop in diagnostics, drop in cancers to operate on. And the interesting thing is that chemotherapy and radiation has been unaffected. So the effect on cancer delivery is in surgery, is in diagnostics, and therefore the flow on to surgery. It's not in chemotherapy, it's not been in radiation, because the ability to determine that, because that's often a longer term treatment, so 3 months or 6 months of chemotherapy. So it's not picked up yet. We expect those numbers to drop because of the same reason that we've seen the drop in surgery. Surgery is a sort of canary, an indication that the drop in cancer services that's happening. So we're expecting and seeing now this on-flow effect of these cancers that weren't diagnosed now starting to come through. Next slide, please. So with elective surgical services, we got the biggest hospitals to rank various operations, and this was sent around and then looked at where there was disagreement. So we got a national agreement on priorities of reintroduction of surgery, and it was decided that case situations where we were going to lead to an acute admission, they got priority. Cancer patients with had a progressive neurological injury, basically spinal surgery, got priority. And people that had pain as a predominant symptom also given priority. And that was across different specialties. Those concepts were applied. And we also moved back to what we'd had before, which was the whole of community resources. So quick negotiations with the private hospitals, and public patients now treated in private hospitals, which are cold centres. No acute work going on there. They just straight out deal with elective. Some of those cases are done on contract. So cardiac cases are just done on contract, paid per case. Others are outsourced, where the surgeon and the anaesthetist will move from the public sector and do a private list in the public list in the private sector in order to keep some theatres that are being prepared for COVID available. And though those theatres are reduced in number, there are still some being marked out, so we've still got those resources maintained in case something should happen. Next slide. So follow-up, many have been deferred. We've delayed a lot of follow-up for cancer patients that are on routine follow-up programs. And also we've put some staff on reassessing them and trying to discharge them. We don't want to waste time following up people that we're going to be tight for resources. Also, all screening, breast cancer screening, bowel cancer screening is on hold for 3 months. And I suspect we'll push that back another 3 months because as what we're seeing is this wave of cancers coming through. Our own service sees about 3 or 4 new bowel cancers a week, and that's now. Sorry, it sees about 6 to 9 bowel cancers a week. And one day last week we thought 13. So that's just reflecting the wave. So that's going to continue for a little while. So we don't need screening cases interfering with what's going on. So that'll pick up again in a few months' time, but it's been deferred for now. Next slide, please. Next slide. Thanks. So we have ongoing issues. Access to PPE is a problem. Most of our PPE comes from America, and of course, as you'll be aware, they've stopped exporting to countries like New Zealand. We have trouble accessing new equipment. Equipment breaks down, needs replacement all the time. We have trouble because we don't have so many flights coming in, bringing equipment in. Disposables and issues, staple guns, everything. Everything's on short supply. We have concerns about patients. They don't want to come and see doctors. They think of us as a possible source of infection to them. Hospitals, the fall off in visitors. They were initially not allowed, and now they don't want to come to see patients. Patients don't like going to hospitals because of the concern about possible contamination. Also, there's a lot of pressure on staff. A lot of staff are very concerned about process of different things. The reintroductions caused a lot of anxiety. And also fatigue. A lot of people have been quite busy working extra shifts, changing structure of workplace. Also, there's a lot of pressure on staff from home because the kids have been home, they've been educating at home, their partners may be made unemployment. There's issues around mortgages, and all that sort of back stuff that's happening to people at home interferes with their delivery at work. And so there's a lot of fatigue and it's getting, and just basically chronic anxiety, which has come to the forefront in people's ability to deliver at work. Next slide. This is the last slide, you'll be pleased to know. So in summary, it's about good management. As I said, we've been here before in many ways. We've had complete disruption, and we're just used to trying to reintroduce services when we don't have enough resources. So I think these are the sort of the 5 main points. Where are you with COVID-19? And that's an individual in America, state by state or country by country. What are your priorities to deliver? Where do you want to put your resources? I told you where ours were, and that was a national agreement. And that was there was some variation where people initially said, but quickly sorted that out. Where are the gaps? Where is the gaps between priorities and what we're delivering? And how can we close them? And the main issue around trying to close them is about where can you get more resources? So what can you not do and where can you expand into? Okay, thank you. Your microphone's turned off, Ronan.
You're on mute, Roland.
Right. Yeah, Frank, thank you so much. How much do you think that your previous experience with the tragedies that you've had before, how much does that prepare everybody for this? I mean, it's a different situation, but I mean, people in Christchurch and I guess in New Zealand generally, kind of had a, well, we've been here before, we can deal with it. Do you think that was a major issue that helped you get through it?
I think it introduced the concept of people following instructions from the government and the idea of military and police being in charge. You know, we can be a rebellious bunch down here, and being told what to do is not always what people like. The ability to just shut up and line up was useful. Also, the concept that things not being available after the earthquake, you know, there were no supermarkets. You had to find some way around that. Now, the supermarkets were still open, but it had to be dealt with in a logical way. So probably the biggest experience for us health is concerned is our ability to understand that we have to work out a way forward and we have to get onto this from the get-go. That you have to start looking, and so collecting the cancer data, getting plans around that, immediately changing the way we deal with acutes, the ability to adapt quickly to what is an evolving situation, and also feeling comfortable cancelling services, no follow-ups, cancelling screening, and not worry about it because it's just not a priority. And we've cancelled them before and reintroduced them, and though there's a bit of a price to pay, it's a small price compared to not delivering now.
Yeah, I think we're going to see a lot of pushback about the delays in screening in Ireland. It's already beginning that people are saying there are going to be lives lost, etc., etc. And you can understand it, but I think, as you're right to say, the priority is you've got to. And your figures are very interesting, showing the drop off in surgery following the drop in endoscopy, and of course there will be the drop in chemotherapy and radiotherapy, and then you've got the backlog and how to cope. Are you looking at extending the working week?
Yes, well, look, a lot of us have reorganised our weeks. This week I'm doing 5 colonoscopy lists as my contribution. So that's just we're working. There's colonoscopy being delivered 6 days a week at the moment because that's the primer for our service. And if we can't scope, we can't deliver. And it's like that across the sector in different areas as well.
Thanks, Frank. Can we move on? Connor, good to see you. You're at the far end of the world from New Zealand, and a very different, I suppose, demographic, a very different incidence now of COVID. I don't know how Ohio is doing, but many places in the United States aren't doing that well. So maybe you can let us know how you're doing and how you're coping, and what are your plans for the reintroduction of elective services?
Sure, Roland, thanks for the opportunity. Happy to take you through it. Erica or Kieran, if you could bring up my slides, that'd be great, thank you. So I'd encourage you, when you think of the US, to think more like Europe. Ohio's got a population of getting close to 12 million now, but obviously the US is closer to 400 million, and states are all different. And if you take out some of the highest incidence, states, actually a lot of areas of the US had a fairly low incidence, and some had almost none. Not quite as low as New Zealand is getting now, but some had very little. And it's changing a little with secondary surges and things like that. But most places, there's very minimal COVID, certainly outside of large metropolis areas. So I'm going to run through some of the things that we've done specifically in the clinic system to address it, and how we've managed it short, medium, and how we're going forward with this. Next slide, please. So the clinic's built around these 3 missions of caring for sick, investigating their problems, and education. We've had a lot of training programs, and there's been a lot of change there. Next slide. And so patients have been put first always, and as we've changed all the care pathways that we've had to change, that's literally been the center of every conversation. Also around caregivers, and Frank nicely mentioned it there at the end, and I'll come back to it later, but we've put together a lot of programs to look after caregiver stress, spouses who maybe have lost jobs, support networks for food and delivery, hotels for people who have to stay around. So we've done a lot of work in that area, and then a lot of work with the community, and then reminding people around the organizational perspective, because if we don't support the organization, we're all independently funded and have to stay financially viable. So that becomes part of at least our equation. Next slide. So the clinic's grown a lot, and it, up until a couple of months ago, had been growing about 5 to 7% a year. And so we see about 5.5 million outpatient visits. We do about 245,000 surgeries. You can see the admissions and the number of hospital transfers that we get. Next slide. And then this happened. So if you move on to the next slide. So this actually impacted us a lot. So we've got 17 hospitals in the US. We've got Abu Dhabi. We've London, which has almost been built, and Shanghai. So I'll concentrate in the rest of my comments on Ohio, but London, for example, was meant to open in March, and building stopped and is restarting slowly. I'm sure, as you're all noticing, all these restarts take a whole lot longer than you expect. And Shanghai now we've put on pause, and we're going to come back and reassess that next year depending on how things go. Abu Dhabi was hit hard early, certainly with volume, although their outcomes have been good. And hospital by hospital, we've seen different perspectives around the US. Next slide. So I'm going to put comments around how we reduced our services, some of the guidelines and safety practices and communication portfolios we put together, how we've modified our practice, and then some of the things we're thinking about as we recover. Next slide. So we worked very closely with the state. So we've, as I mentioned, a large number of hospitals in Ohio, and we worked very closely with the state, and so worked with the governor and medical director for the state to come up with recommendations for how we would tier back surgery. And then we worked with all of the regional hospitals to make sure there was consistency across all groups. And what we did was defer non-essential surgeries, and these were the definitions of essential that we used. Happy to send the slides around as a PDF if people want the details, but largely around threat to life, permanent dysfunction, cancer progression, or severe symptoms. Next slide. We also adjusted it after several weeks. The fifth point on the last slide, you don't need to go back to, but it was progression of symptoms, because we realized that rapidly worsening symptoms wasn't enough, and there was a population of patients who were having fairly severe symptoms that were not being managed appropriately promptly. And so we put together algorithms for managing these patients, because this was before we were testing patients routinely for COVID before all surgery. Next slide. We tiered each department within the Institute of Digestive Disease and Surgery, but also each institute from neuro through heart and vascular, etc. And we came up with gradations of cases that we were able to share across all hospitals and all groups. So we'd have standards as we worked, and many of these ended up getting implemented statewide. And Dr. Mihalvik, the CEO, ended up working closely with the White House. So a lot of the national standards that came out were based on some of the practices that we developed. Next slide. So we get about 25,000 transfers a year in as a system, and the vast majority of those are to main campus. So we also came up with tiers of transfers that we would accept as guidance for transferring institutions, and that allowed us just manage the transfer volume more carefully. All of those were based on, at the time, a lot of work that went into managing our PPE, our supplies, blood, hospital beds, ICU beds, etc. Next slide. So we developed fairly rapidly a series of work streams, PPE and reuse. That was everything from supplies. We had a critical incident team who in January started keeping supplies and not cycling supplies that were out of date in case we might use them. We developed hydrogen peroxide methods for re-sterilization of masks, which we still haven't used. We've still been able to say just ahead. We put a lot of work into data and analytics and how we would map out both the curve of cases, but then particularly how we would map out use of hospital beds, ICU beds. In the system in Ohio, we've got about 500 ICU beds, and so we mapped out what we would need for cardiac care, for emergency ICU, and then how we would build in the population surges of COVID cases depending on their bed utilization. The other things, I'm sure you did similar things, but labor pool was actually one that was very important in the beginning. We looked at areas that were less busy or that patients weren't coming for, and we redirected staff, nursing, administrative, others to new tasks that opened up, and to rapidly scale how we did virtual visits and phone calls, how we tested all people coming into the institution, etc. And then top of the middle column is also important. We put a lot of effort into communication, and that was everything from daily communications through webinars like this to staff in the organization, to daily newsletters, to working with the board, CEOs. Regionally, we did a lot of regional communication as well, again, to message around how to manage the condition, how to manage the disease, and how to manage all the consequent challenges that are part of it. Next slide. So this is our Ohio census. In the first couple of weeks, we had a peak that matched many places. Fairly early, we got on board with social distancing and many of the other restrictions and mask wearing that others have done. And so we flattened our curve pretty quickly. And it's coming down now gradually. Again, not to New Zealand levels. And what you see in the yellow, orange, blue, and lighter blue lines on the right is how our modeling team have modeled what secondary surges may happen as each component of social distancing is relaxed. We are back to having most industries open, restaurants open, everything really short of movie theaters and sporting events is back open. People will wear masks in close proximity, but are walking in the streets and other things. There have been no restrictions like there were in Ireland about moving a distance from your home, and we've still been able to control things reasonably well. Next slide. So this is one of the dashboards that we developed, looking at days of supply. What we did was realize that the dashboards that we had that showed us what we had in storage were not adequate for mapping out the new utilization rates, because obviously the new utilization rates of N95 masks, eyewear, isolation gowns, etc., were dramatically different to our historical rates. So we modeled those, and we brought in all of the population curves, modeled in the incidence of disease, and mapped out how many days of supplies we would have moving forward, and even at a far more granular level than this. So we were down to different N95 sizes, looking at blood, beds, etc. And so this allowed us manage our resources, and it also allowed us have data early on that we should build a secondary hospital. And so we converted our medical school to a 400-bed hospital, which we got close to using, but haven't needed yet. And if in 4 weeks we haven't needed it from now, we're going to return that to being a medical school again. Next slide. This is one of the bed dashboards that we developed. As you can see the total acute beds available, ICU beds, ICU occupancy, and this dashboard also has the COVID-19 status and census. And so we map this daily. As of this morning, this is a few days old, but as of this morning, we had 96 patients in-house in the Ohio hospitals with COVID, and about 45% of those in ICU. Next slide. So this is some of the information. We've got intranets, and then we have externally facing websites. And on that, you'll see in the lower center part of that graphic is a COVID-19 toolkit. If you can click the mouse there one time to see the next graphic, please. And under that toolkit, we have everything from how to manage reactivation, how to manage detection, resources for caregivers, ICU, ER, nursing, operating room, and anesthesia. And so we put teams together developing many of these so we'd have standardized management practices across the organization. And then we've used the website as our consistent source of truth, because many of these change with updates in how we're managing the disease or other things. And so this is our source of truth, and PDFs such as the next visual are generally not used. So this is the PPE recommendations for caregivers in procedural areas and operating rooms. And largely we keep N95s for intubation and for people who are having aerosolizing procedures. And largely now this is defunct because we routinely test all patients before surgery for the last 4, maybe 5 weeks now. And so this is only for patients with unknown status or patients who are COVID positive. Next slide. This is one of the Institute briefings that we do, and this has been a daily briefing since the start of the pandemic. And this is one sample agenda. Leadership update, numbers update, the HEC is the new hospital we're building, scrubs, but this agenda might have equally read new agents being used managing the disease, new care pathways, recommendations from the virologists, etc. And so this agenda would change day by day to message information as quickly as possible to teams across the organization, and would be followed up immediately at the conclusion of the call with the PDF of the slides that were discussed, so people who couldn't make the call would be aware of what was going on. Next slide. This is the first slide of each presentation, and it's the inpatient census. You can see it goes up to a few weeks ago. It's a little out of date, this, but you can see at our peak, we got to 150. And then a couple of weeks later, we got to 162, and now it's tapered back down to 90. Next slide. So other things that we've done, and again, I'm sure you're all doing, but we have a lot of acronyms at the clinic, probably too many acronyms, but one of them is 6 feet away from everyone. You can see how we've mapped out different areas for how many patients we would have socially distanced coming into clinic or other waiting rooms, elevators, visitor restrictions, who can come in, who can't come in. Next slide. Workforce transition, we transitioned an awful lot of people to working from home. And actually it's made us think about how much space we need now going into the future and some of the new buildings we were considering. We're staggering shifts for a couple of reasons. One is social distancing. One is something we were doing anyway, which was to try and manage caregiver expectations and flexibility. And this is just integrating well with the pandemic we're going through now. Next slide. Surgical reactivation we've done in a phased approach, focusing on quality, safety, access. We've minimized our utilization of PPE through standardization, blood and beds I've talked about. We've ramped volume down initially, now we're ramping it up in a very graduated way based on the tiers that I showed you. And we implemented preoperative COVID testing, and this was for 2 reasons. One was for patient safety, having a major operation to make sure they wouldn't have a respiratory complication. And the second was for caregiver concerns, because people were simply afraid of and nervous to look after these patients. And we've used cohorts very carefully. So we have work streams, for instance, for endoscopy. If it's a separate work stream and the patients don't touch tested patients, we will have non-tested patients go through endoscopy. Next slide. So we've reopened in phases. The first phase was the ambulatory surgery centers, and then centers of excellence like the Orthopedic Center of Excellence. The hospitals never went to 0, at least not our hub hospitals, before hub hospitals in Ohio. But then their third phase was rescaling elective cases at the hospitals. Next slide. And so you can see this is how we've ramped back surgical volume. We do about 770 cases a day, and we're currently in phase 3. We're at about 93% of recovery of volume as of today, so getting close to 770. Next slide. So within DDSI, we've a significant amount of volume of cases, about 14,000 inpatient, 34,000 outpatients, and a lot of endoscopies. We also have a fairly sizable transplant program, doing 180 liver and small bowel transplants. So if you can go to the next slide. So all of these have very different concepts, and so we managed each section very differently. So trauma obviously didn't change. It actually changed slightly, and that there was a little more blunt trauma. We saw a spike in home violence with all of the people at home. We saw less penetrating trauma, but the care pathways didn't change. And then transplant was probably the single biggest change pathway, where we set up closed units that are COVID negative for both the cadaveric program, but also for the living donor program, and particularly for the living donor program. Next slide. This is an interesting slide because what it shows you is what we did with synchronous visits. So towards the left of each graphic, you see that light brown in-person visit, and we were doing about 5% of virtual visits a day. And you can see GI hepatology and nutrition actually swung to being about 95% virtual visits. Surgery and colorectal surgery were very subspecialty dependent, but obviously more physical exams. So we've swung hugely to virtual visits, and we now estimate that we're probably going to end up being about 35% virtual visits going forward, looking a few months out. Next slide. You can skip this slide. This is what happened to our endoscopy volume. The daily volumes dropped by about 2/3. Our overall surgical volume dropped by about 55%, but endoscopy dropped a lot around screening and upper endoscopy. And this is a couple of weeks old. As of today, we're back up to about 85% of endoscopy volume. Part of that's been driven around our sites as we've reopened sites in that staged manner that I told you. Part of it's patient nervousness coming in. Screening procedures they often feel they can put off. And Ronan kind of briefly alluded to the challenges with that and the diagnostic rates for cancer. Next slide. We've developed workflows for surgery around testing, how this is communicated to patients, what happens if somebody tests positive, how long we keep them before operating on them for elective surgery, what happens if somebody's negative, or what happens if somebody doesn't have a test. And what this has allowed us to do is manage all of the operating rooms so there's no mixed expectations between nursing or anesthesia or a surgeon who might want to do a case. Next slide. And this is the decision tree around screening for symptoms and COVID testing. But essentially, most of them leading towards proceeding with surgery as long as appropriate PPE are used for patients who have surgical indications. And then one of the other legal things that we've had to change is that on a statewide basis, we have to have a discussion with the patient around the potential risk of COVID. Next slide. So Frank mentioned this. We've put a lot of effort into the caregiver workplace, and we've developed programs to support the caregivers. I mentioned food, transport. Next slide. We've also put together actually skip this, go on one more. We've actually worked closely with psychology to put together stress management programs for patients and for caregivers, and to open up slots for caregivers to see our psychology teams, usually virtually. But the amount of stress that this has caused for caregivers has been really significant. Both fear of getting the disease, fear of managing it, and particularly fear of bringing it home. The good news is we haven't seen people get it at work. Our regional prevalence is about 0.5%, and the prevalence within the 66,000 people working here at the moment is about 0.55%. So we're really at community-acquired incidence rates. So moving forward, our current priorities are to continue to stress to patients how safe it is to get care. We haven't had patients get COVID when they come to the hospital. We're working hard to increase our clinic activity to give access to patients. And that's particularly because there have been enough people who've lost jobs and that it's more challenging for them to come at certain times, or they have restrictions around taking time off from their jobs. We've scaled a lot of virtual care, as I mentioned, and also non-traditional. So we're doing early morning clinics, evening clinics, and weekend clinics, which were about 1% of what we did, and already now are 5% of what we do. One of the important things is we've tracked and reviewed all of the deferred cases. So any surgical case that got deferred went in a database, and we've gone through that database based on priority to reschedule those cases for surgery, to bring them in for needed surgeries. And then obviously we're continuing efforts to maximize quality, efficiency, and value throughout the organization. And this is really allowing us change how we look at a number of different issues that are ongoing. So Ronan, moving through a lot of different points of things that we've looked at, and happy to follow up in future with anyone if it's helpful.
Hi, did baby arrive? Great, Daniel. And
Conor, thank you so much. I think there's a job waiting for you in the next Irish government. Minister for Health, you've achieved so much, and you've got the clinic and your very large numbers of staff, but also your population. You've got it simply delivered a fantastic response. I think in the interest of time, we'll defer questions to the end, and I'd like to ask Mike Griffin to give us a view from the UK. UK, very similar health service to what we have in Ireland. I think it's been stretched a little bit more than we have. And I'm sure, Mike, you'll deal with the current situation and recovery, but perhaps at the end, maybe some reflection on the implications for training, which you and I have talked about quite a bit, and particularly assessment of our trainees. So thanks, Mike.
Thanks, Ronan, and thank you for inviting me to the webinar of my favourite college. It's a delight to be here. First slide. I've been asked by Ronan to talk about how it all happened in the UK, and then how we've responded and how we're restarting work again, elective work in particular. And I think it's quite useful to go through a little bit of the history. It seems like an age now, but it's only actually been about 16 to 18 weeks. January the 31st was the first 2 Chinese nationals that came from Wuhan to York and were diagnosed with coronavirus. And it was an interesting response from then by the Public Health England, that they said that the close contacts were just given health advice, they weren't quarantined, they weren't tested, they were just told to get in touch if they felt ill. The emphasis was on the relatively low mortality rate associated with coronavirus, and that was emphasized. We then moved on the following week or so, and a UK citizen, and many in Ireland will remember this, who had been to a meeting in Singapore, came back via a ski chalet in the Alps, and he was known as the super spreader because there were 11 people in that chalet. Came back to Brighton and to Worthing, and he was diagnosed with coronavirus on February the 6th. And again, no quarantines for any of the contacts and no testing at that time. And the first death in the UK was, in retrospect, was logged on February the 28th. And you can do the maths, it's only a number of weeks ago. And yet, and this is probably relevant to Ireland and the Irish, because I think they came over in their numbers to Cheltenham on March the 10th. The Cheltenham Festival was still open, and huge numbers attended the Cheltenham Festival. And the next day, Liverpool played Atletico Madrid. And as you will all know, Spain was being badly hit by the COVID-19 epidemic, and that happened on March the 11th. By the April the 9th, on April the 9th, we recorded 980 deaths in the United Kingdom on that date, and there were, just to finish the story, at the weekend just passed, on the Sunday, there were 36 recorded deaths, although on Tuesday, that was yesterday, 233 deaths were recorded. You can see from the graph there about how the number of coronaviruses infections are reducing, but you can also see that we've been hit very, very hard during the end of March and the whole of April, and the peak of this epidemic was on April the 9th. Next slide, please. So what was the UK Royal Colleges? I'm president of the Royal College of Surgeons of Edinburgh. We have 30,000 members and fellows all around the world, and we have about 16,000 in England. And we were very much involved in the government response, in as much as we were involved with weekly chief medical officer meetings and also with the National Medical Director each week. And that started in mid-February, which felt as if we were well prepared. But the whole focus at that time was on NHS capacity and the ability to manage the very sick patients with COVID-19. And that meant the patients that would need intensive care and therefore potentially ventilation. And so very much the accent was on identifying ventilators. We had companies changing their work practice to make ventilators. We had Dyson, instead of making Hoovers, they were making ventilators. So very much a focus on capacity and being able to deal with the huge number of sick patients that may come. And what became clear during March was that the strategy for dealing and containing the virus was dictated largely by resource rather than by the science. And in that regard, it was an absence of testing, and the one thing that the UK was not prepared for was doing huge numbers of tests. We came to that late, and by April we were able to increase the number of tests to nearly 100,000 a day, but that was not there at the beginning, which in retrospect we may have learned a lesson. The key thing was moving from the contain the virus to delaying the outcome of the virus, which was pushing back the peak, flattening that curve, trying to move that peak of numbers to the summer rather than the spring. And then, of course, as the epidemic took hold, there was the concepts of social distancing that we've heard with the previous speaker, isolating the vulnerable and shielding those with serious comorbid conditions, and reconfiguring NHS services. And by that we mean we cancelled all elective surgery. So all elective non-cancer surgery was cancelled completely. Indeed, quite a significant proportion, certainly well over 50% of all cancer surgery stopped, and I will come on to that. Next slide, please. This slide is just to give you some of the challenges that we faced. The couple of pictures of the Liverpool Atletico game, the Cheltenham Festival, but also PPE and the challenge that brought to us, because the one thing that became absolutely clear quite early on in the pandemic is that we were significantly short of personal protection equipment. And that was a real concern for the colleges, and particularly the surgical colleges, because our ability to continue to provide urgent and emergency surgical care for ongoing emergencies, and also what cancer surgery that could continue, really was crucial to have the appropriate PPE. And that was a concern. The advice from Public Health England in the first instance, we felt as Royal Colleges was perhaps not the best to protect our members and fellows. Indeed, it was quite a fight from the colleges to get things like upper GI endoscopy to become recognised as an aerosol generating procedure. And these aerosol generating procedures were continuing, these endoscopy lists were continuing well into towards the end of March. And it was finally recognised that these needed to be managed with personal protection equipment, because the potential to transmit the virus in the hospital environment was significant. Testing, again, a problem because there was a relative lack of that testing facility during these times, and that was a concern. And then, of course, the other pictures are in the aftermath of the pandemic and the easing of lockdown, which, with the good weather in May, resulted in a mass exodus to the beaches and not much social distancing. And of course, there's also been the recent demonstrations about Black Lives Matters and the death of George Floyd, and of course the many demonstrations throughout many of the UK cities without an awful lot of social distancing. Next slide, please. So we come on to where we find ourselves now, which is the progress, the restart. And so Simon Stevens, who's the chief executive of the NHS, he indicated to us about 5 or 6 weeks ago, he indicated that, just using that slide, that's it. He wrote to us and said that in addition, and I'll read it here, in addition to establishing this non-COVID urgent service, he asked all management in the NHS, in all the hospitals in England and Wales, to consider restarting and looking at the feasibility of restarting an elective service. And so we were charged to do that. Next slide, please. And I think all of us, the colleges in particular, the surgical colleges, felt that this needed to be done with caution, because as I'd indicated earlier, easing the lockdown was needed to be done in a cautious way. The government were quite clear about that, because what we had seen during lockdown was the incidence of trauma, of road traffic accidents, of sporting trauma had massively decreased during lockdown for obvious reasons. But with the ease of lockdown, we immediately saw increase in numbers coming into the emergency room with trauma and also of injuries, particularly around the coast. There was a lot of life-saving going on with people getting into trouble in the good weather. So there was, and this was on the back of the risk of a local or even a national surge in numbers of cases again. And the key thing is that we were having still and are managing emergency and urgent cases expediently. This is not disaster surgery at the moment, but we were still having to provide this. And of course, there were the infection risks and the risks of transmission of this virus. And the perception from the general public, of course, was they were staying away from the National Health Service because initially, I think because of public spiritedness, that there was a view that they should not be troubling the NHS when it was under huge pressure and the staff were under huge pressure, which they were for the weeks at the end of March and in the middle of April. And those infection, but latterly, the view, I think, is that the general public were avoiding going into hospital for any kind of surgical procedures or investigation for significant and worrying symptoms because of the risk of infection with COVID-19. And we saw a 75% decrease in referrals in for 2-week waits for cancer. Patients did not present themselves and would not come to hospital. And so that it changed from a public spiritedness to a frank fear of coming into the one place where they thought they were likely to get it. And of course, now that is exactly the case, because the highest risk to any patient would be in the hospital environment now, or in a care home, but that is decreasing now. So that the risk initially in all but then now that has changed from staff to patient, and of course the transmission rate and the R value in hospitals is much higher than in the community, staff to staff, and of course patient to patient. And this gave rise to the concept that we as a college put forward, was for COVID light sites. In other words, hubs where within hospitals or outside of hospitals, in the private, the independent sector, or even in the Nightingale hospitals that have been set up to provide sites where there would be less risk of COVID-19 and perhaps a safe place for surgery to be carried out. Next slide, please. So the readiness to restart was a concept that was brought out by the Royal College of Anaesthetists, and they produced a very interesting and good document that outlined the necessity to get a recovery management team together, and that the criteria to fulfill were the 4 S's, really: space, staff, stuff, and systems. Space, you had to identify theatre space and ICU capacity, which of course had been significantly reduced because of the need to use theatre spaces for ventilation. The staff, the availability of the entire team, and this was not surgeons who had been, a lot of them been lying fallow, particularly orthopedic surgeons, but the anaesthetic nursing staff, the physiotherapists, all the nursing staff who had been redeployed, working in strange environments and who had undergone very stressful situations and worked extremely hard, coming back to the whole concept of well-being and the concern that this that asking them to return to hot and heavy work was a difficult one. So we had to make sure that the availability of the team was there. The stuff, the equipment and drugs, obviously in short supply. This was mentioned earlier. I still think that there is a shortage of propofol in the UK at the moment. And the systems, the pathways, getting the COVID light environments for safe surgery, and making sure that there was strict infection prevention and control. Next slide, please. So a lot of work went on about over the last 6 weeks in preparation for a restart, and this was on prioritization by pathology, and this was an intercollegiate effort along with NHS England, and this guidance basically went through all of the specialties with the exception of obs and gynae and ophthalmology. And the idea was to go through every single operation, cancer and benign, and documenting what level of priority they were. And you can see on the slide that we had 4 essential priority levels. 1A, which was emergency, which is an operation that needed to be done within 24 hours, which happened anyway. 1B, which was urgent, which had to be done within 3 days. Level 2 surgery that could be deferred for up to 4 weeks, and some surgery that can be delayed up to 3 months was level 3, and priority level 4 was the elective stuff, which hip replacements, knee replacements and the like, surgery that can be delayed for more than 3 months. And so all specialties all the specialty associations and the colleges had input into this. It was a huge piece of work, but it actually documented what level of priority each operation had, such that managers and clinicians would have some idea of surgical priority. Next slide, please. And of course, there's prioritization by risk, and you have to identify patients who have significant risk, of having an operation, particularly an elective operation, in a COVID-rich environment. And therefore, patients with asthma and chronic lung disease, diabetes, severe obesity in particular, age over 65, and immunocompromised patients such as cancer patients and transplant patients. And these patients obviously represented a significantly higher risk of infection with COVID in the post-operative period, and this could be catastrophic. And so you would not, perhaps, if you had someone with a slipped knee replacement who was getting bone loss, who was 82 years of age, you may wish to postpone this for some time to a later date and a safer date, rather than a 55-year-old who was in the same situation. So risk prioritization was there. Next slide, please. But what is the risk? I mean, we need to evaluate this risk, and I think this hasn't been touched on yet. And two papers in the Lancet recently. One was the Wuhan paper, which outlined the outcomes of surgical procedures, significant surgical procedures, both in the emergency and in the elective scenarios. And also the COVID surge paper, which has come out looking at Italy and looking at the initial results in the UK of continuing to do emergency and major elective surgery. And the results, the outcomes were, if COVID was involved in the perioperative situation, that patients got either they were operated on with COVID or they developed it in the post-operative period, there was up to a 40% mortality. So these are significant risks that had to be taken into account, and that comes back to the concept of developing the COVID light pathway. And whilst there was no directive from NHS England, trust boards and health boards got together and looked at how they could provide COVID light pathways to continue cancer surgery in the hot and heavy environment. And indeed, college did a survey that looked at what had happened under these circumstances, what had happened to cancer surgery. And the reality was that in May, 35% of hospitals had stopped all cancer surgery completely, and that 87% of surgeons had stopped or reduced operating on cancer. The reassuring thing was that when asked why they had stopped operating, it wasn't because of lack of resources. It was 85% had stopped because of the risk benefit, the worry for the patient, and that was why they did it. And again, this comes on to the concept of how you can reduce the risk in this COVID-like pathway, which is all based around isolation, screening, and testing. That means that a patient that is going to come into a COVID-light pathway, that patient is tested with 14 days prior to them coming in. If they're negative, they isolate for 14 days, they come in, and 48 hours before they're tested again. And if they're negative, then they're highly likely to be COVID-free. But that is only going to work if they're coming into a COVID-light environment and the healthcare workers are equally COVID-free. Next slide, please. So the key principle about COVID light is for elective care is that you have to make sure that the patient is screened, it's tested negative, and is isolated pre and post operatively, and they're physically separated. The whole thing is physically separated from the hot and heavy COVID rich environment. The staff are separated and they have to be tested. And there was a concern because of the lack of the numbers of tests. And at first they were suggested that they were going to be tested every 2 weeks. Of course, this was not acceptable. Certainly in Hong Kong and Singapore, that healthcare workers in this environment are tested every day. And we're calling, and as surgical colleges are calling for this to be 2 or 3 times a week at least, and that the ring-fenced facility is there. And of course, the COVID-rich environment, the urgent and emergency work still has to go on because the testing status there is unknown for the patients coming in. Next slide, please. So are we ready in the United Kingdom to do all of this? And we have surveyed all of our members and fellows. We've done that with the British Orthopaedic Association as well. And we've asked the question, do we have PPE? Because there has been a significant lack of PPE during this pandemic within the NHS, which has caused considerable worries and problems. And the answer is that that appears to be solved now, and there was support and from across the United Kingdom that there was adequate numbers of volume of PPE. And we asked whether the hospitals had identified COVID-light hubs. Slightly worryingly, up to 3 weeks ago, only 60% of hospitals had identified these hubs or independent sectors, private hospitals that had been commandeered by the NHS to be able to do this. Waiting lists had to be reviewed. I mean, do you want to come into hospital? Do the patients want to come into hospital? And it was interesting that 60% had expressed the desire to wait and not to come into hospital for their elective surgery. And with consent forms, because with COVID-19 around, consent forms have to be changed. The informed consent, the whole consultative process has to change in the light of the risks of COVID infection in the post-operative period. We asked about staff screening and testing, and disappointingly, only 50% felt that testing was going to be made available to healthcare workers on a regular basis. And so this was also still a significant concern. And this feeds into the problem that I raised earlier on, which is the trust and confidence of the British public. Because for us to be able to encourage patients to come back to the NHS for much needed investigations to rule out or to confirm the presence of a cancer, for instance, we have to win the trust and the confidence. And therefore, test is key for healthcare workers and for patients, and staff screening is essential. Next slide, please. Thanks very much indeed. Delighted to answer questions.
Well, Mike, thanks very much indeed. I think you've got it in one there at the end, that the answer to this is trust and confidence. One just worries that in the UK, but also in Ireland, that we've got a way to go to have trust and confidence. I think, Conor, you've done a magnificent job, and it's very clear from the very, very detailed way that you've approached it that it's likely that you've got the trust and confidence of the population. But that remains to be seen when your figures come back up to what they are. And indeed, the rest of us are in awe of what has been achieved in New Zealand, where really you have, with the exception of the 2 people who've come in and have proven positive this week, you've eradicated the disease, and so you're back to where you were. So 3 very interesting perspectives. In the interest of time, I'm going to ask Kieran whether he has had some questions in from our audience and whether we can quickly address them.
Thanks, Ronan, and thanks to all the speakers. There's been very little coming in on the chat function, and I think that's probably because everybody's paying so much attention to all of the great detail that was presented. I guess that one of the big questions that has come in though in the past, and that the college is struggling with, and I know, Ronan, you've brought up a lot of times, is the impact on training. The impact on training, and maybe in Conor, in your case, the residency programs, it'd be interesting to hear what happened there, and how we can get a good quality training again, given that services have ground to a halt in Ireland and the UK. It'd be good to get perspectives on that.
Yeah, absolutely. So I think it was a real concern early on, particularly when we were on that rapidly increasing part of the curve, and we were very worried about PPE, and that was really our primary driver. And one of the discussions we went through early on was whether we should take the trainees out of a high-risk environment, whether, well, all of the other consequent decisions, and we decided not to. We decided that this was an important part of their training. We very quickly had put together pathways that we felt were safe for PPE, for wearing the right thing in the right place at the right time with the right patient. So the trainees stayed as part of the program, and particularly for surgical cases. Where we didn't have them involved in the first 4 to 6 weeks was around endoscopy. Just because of the volumes, it was using an awful lot of N95 masks. So we felt they were unnecessary people in high volume rooms. And so that was the one place that for the first 4 to 6 weeks we took them out of. And then visiting trainees, we've stopped. And we're probably going to restart visiting trainees later this summer. Likely going to be July or August. But they're the different strategies we've used. But largely it's been about preserving training, because we've found that people haven't been getting COVID in the hospital, and as long as the right PPE has been used, it's been safe. So,
Frank, what are you doing in New Zealand with the trainees, and are you sending them out to the private sector if work has been seconded to the private sector?
So there's been various different things sort of happen. Like Connor, we pulled them out of endoscopy, and endoscopy became a consultant-led service alone. Our normal delivery would be impossible without our residents, because, but like the NHS, residents are such an integrated part of the service delivery, so we couldn't cope without them. With the numbers required, their logbooks and those numbers took a hit with elective services, and now just what you suggested, they are actually participating in the private and the operations in the private sector and doing the operations in a supervised manner in the private sector in order to get their numbers up. But their numbers will be low, and we've accepted that as just an inevitable outcome. A couple of other things that have happened is selection processes for training programs have been delayed, and normally they will have all happened already, and they're actually happening at the end of July. So they've been delayed to that. Our exams that were due in May have been delayed, and exams in June have been delayed, and they'll all happen in October. So that will have some consequences, because people coming to the end of their training will be applying for fellowship positions. Then there's an unknown amount there. Because we're a nation where we tend to travel a lot of our trainees would, once they've finished training in New Zealand, would move to the UK, Ireland, the US for post-fellowship training. And of course, that door's not open to them now. So we're anticipating a lot more demand for in-house fellowships across Australasia for the next while, because we don't see that there is an appetite for a lot of our senior trainees to travel to high-risk countries. Also, I don't think there's an appetite for high-risk countries to have people come from the end of the world. So there is an issue there which is unsolved, but we'll see how that, this is an evolving matter, and the ability to change and adapt is key.
I have one last question for each of you. What are the long-term benefits of this experience? And we might start with you, Frank, and then work our way around the world.
Look, I think one of the things that's alluded to by the other two presenters was the movement to using more clinic appointments by internet. Now, when someone gets a clinic appointment, they get offered a face-to-face, they get offered a Zoom appointment or a telephone appointment. A lot of older patients don't cope with Zoom, they're quite happy with telephone. And Connor talked about a third of his patients moving that way. At the moment, we're running about 50% of our patients wanting it that way. And now they have the opportunity, they choose, and we're happy to work with that. So there is an increasing alteration to resources and the work from home phenomena. So this has been the biggest driver to IT. Just look at this meeting. This is the biggest change that's come of this, is the use of IT.
Connor, long-term benefit. What's good about what's happened?
I think Frank nailed it. A lot of virtual care, a lot of meetings, a lot of efficiency. I think the other thing for us was speed of decision making and speed of change. And we realized that you know, we're a kind of complicated organization in a lot of spaces, but we were actually able to implement things, you know, within days or a week across the organization, and through a lot of people coming together. And it's always been a very collaborative organization, but we had, you know, we'd have meetings of everybody from surgery to operations to infectious disease, infection prevention teams, quality. You know, we'd have 20 people on a virtual meeting, and we'd make decisions and we'd implement them. And we set up new approval processes through our operating council. So to come to us again on operating council or the executive team for different, depending on which work stream it was through, and we'd implement it. And I think that's really going to last. And we're already doing things more quickly. And we used to go through with the concept of trying to get input from as many people and be as inclusive of as many people's opinions as possible. We probably spent longer than we needed to doing some of those things.
I hope it's the end of the stakeholder myself, but there you are. Mike, last words to you. What's good about this?
Well, before I say that, I should probably say something about training as well. You didn't ask me about that, and training in the UK is a bit of a worry because we've been hit far harder than New Zealand, and from what sounds of things, the US as well. And our trainees were all redeployed. There was no elective operating, and that hasn't happened since February. And furthermore, there's been difficult in career progression because the MRCS and the FRCS exams have not been going on, and we are looking at those exams going forward because we have to make sure that we can try and deliver them by the end of the year, and that is still a big ask. I can tell you, it's a big ask to do them in the same way, the clinical exams in the same way. So we're looking at the way we deliver those exams to make sure that this can't happen again if we have regular pandemics, if you like, or if COVID doesn't go away and there's no vaccine. Coming back to what is good about this, Frank got it in one. I think that the whole consultative process is changing. General practice will never be the same. They are going to do so much on virtual consultations. It is working extremely well. I think that a heck of a lot of surgical consultations could go that way as well. At the moment, it's around about 70%. And I can see that that is going to save a lot of time, money, and effort. So I think that is good as well. What has been extremely clear is the speed at which we can put things into place during this crisis. I think that from a managerial point of view, that everything has been expedient, if you like, and that government have been malleable in making that happen, and also our regulator, the General Medical Council that regulates our exams and our processes, they have changed a lot to make things happen quicker. So I think that is what I would say is that we can get change for the better quicker as a result of this.
Sorry, I'm just unmuting myself. Can I really thank all three of you for giving of your time? It's been very informative for our members and fellows. I hope you three also have got something out of it. Frank, you've had a very early cup of coffee, I suspect, but it's been really very informative for us. Can I thank Kieran, Paula Mansell, and Erica Sullivan in the background, and Porrick Kelly as well, who have set all of this up from our standpoint. It is truly extraordinary what, I mean, who would have thought 4 months ago that we could just have this type of meeting right around the, I mean, I don't know how many time zones, but we've had it, and the video and the audio are just perfect. So thank you all three. We're very grateful, and I hope to see you in person in the not too distant future. For goodness sakes, don't all of us ritually burn our frequent flyer cards, but there you are.
There you go.
Thank you all.
Cheers.
Have a good evening.
Bye, everybody.